their ability to get reimbursed. And I think this may be a win-win. Thank you.
Gentleman yields back. Chair now recognizes Ms. Norton from Washington, D.C.
Thank you, Mr. Chairman. Today we are here for yet another hearing on a very important topic that Democrats have long worked to address: high drug prices. The high cost of health care is a burden on individuals and families in the United States. Prescription drugs are too expensive across the board. 2023 polling by the Kaiser Family Foundation found that 3 out of 10 Americans have not taken their medicine as prescribed because of high costs. A 2023 report from Patients for Affordable Drugs found that for certain cancer medications, some patients spend up to $16,500 out of pocket. I would like to ask each of our witnesses today, Mr. Kotzner, yes or no? Do you agree that we need to do more to lower the price of medicines for people across the country? Yes or no?
Congresswoman, there is always more that we can do to lower patient out-of-pocket costs, and we'd certainly be happy to offer some recommendations on how we and Congress can do that.
Mr. Joyner, do you agree that we need to do more to lower the price of medicine for people across the country?
Congresswoman, I agree, and that's the role of the PBM, is to continue to create competition to lower cost for the customers in which we serve.
Thank you. Mr. Conway, do you agree that we need to do more to lower the price of medicine for people across the country?
Yes, we need to do more to make medicine more affordable for the people across the country, and that's what we work on each and every day.
I appreciate that, because it seems pharmacy benefit managers are a factor in these unacceptable high costs. An interim report published by the Federal Trade Commission this month and a New York Times article in June found that pharmacy benefit managers contribute to rising out-of-pocket drug costs, including by steering patients away from cheaper medications like generics. The bottom line is that high costs are harming Americans. Fortunately, the Democratic-led Inflation Reduction Act that President Biden signed into law in 2022 is already addressing these high costs. The Inflation Reduction Act caps the amount someone on Medicare has to pay out of pocket for insulin at $35 per month. This is estimated to save $500 per person per year. Capping the cost of insulin so everyone who keeps it can afford it will save lives. Nearly 7 million Americans rely on daily insulin, about 4 million of whom will directly benefit from the $35 Medicare limit set by the Inflation Reduction Act. The Biden-Harris administration is working to expand the $35 insulin cap to all Americans. Already, several insulin manufacturers, including the largest manufacturer, Eli Lilly, have committed to lowering the cost of insulin by 70% and capping out-of-pocket costs at $35 per patient, not just those on Medicare. The Inflation Reduction Act also limits out-of-pocket costs for patients covered by Medicaid Part D to $2,000 per person beginning in 2025. Patients for Affordable Drugs has found that 99% of cancer patients who use brand medications will benefit from the Inflation Reduction Act's $2,000 cap on out-of-pocket costs. This is estimated to create annual savings at $7,590 for those patients. Overall, the Inflation Reduction Act will improve lives over 1.4 million Americans covered by Medicare. It will also lead to an estimated $7.4 million in savings in annual out-of-pocket costs for enrollees. The Inflation Reduction Act has and will continue to benefit Americans who face burdensome high-cost prescription drugs. I hope the pharmacy benefit managers here today will commit to actions that similarly benefit American families by reducing the cost of medications and increasing patient choice and access to medication. Thank you, Mr. Chairman, and I yield back.
Gentlelady yields back. Chair now recognizes Mr. Fallon from Texas.
Thank you, Mr. Chairman. We all know that, look, the cost of health care has steadily increased, and it's an environment of already record-breaking inflation. More and more Americans are foregoing health care coverage because they simply can't afford it. PBMs state that they exist to save people money, yet the PBMs are seeing, quite frankly right now, sky-high profits, and health care costs are becoming prohibitively expensive for the average American. According to the Federal Trade Commission, 3 PBMs now control 80% of the market. They vertically integrated with suppliers of goods and services, retail, mail order, specialty pharmacies, and large health insurers. And as a result of vertical integration, there are pharmacies owned by the same company as the PBM they're linked to, quote-unquote affiliated pharmacies, as well as local and independent pharmacies, which are known as unaffiliated pharmacies. Each one of you here today represents a group that is integrated insurer, PBM, pharmacies, and provider services together. So for the witnesses here, Mr. Conway, Joyner, and Kotzner, what is your relationship with your respective companies with independent and unaffiliated pharmacies? Would you describe it as positive or negative, Mr. Joyner? Just positive or negative, because I apologize, we have limited time.
Yeah, I'm just saying, Congressman, I think independent pharmacies are a critical part of our network.
So you would say, you would describe your relationship with them as positive?
I would, and we also reimburse them more money, so I think that's one of the benefits of the relationship.
Dr. Cosner?
Congressman, we have worked hard very recently to make it a positive interaction with independent pharmacists.
And Dr. Conway?
The goal is also positive and support independent pharmacies and pharmacists.
And the same thing, I'd like to start with Mr. Joyner. Do your companies steer patients to affiliated pharmacies? Yes or no?
We actually establish a variety of different network options.
And again, at limited time, yes or no?
So the answer is no.
Okay. Dr. Costner?
No, sir. Our clients make the decision on what pharmacy networks they want to use for their patients.
Dr. Conway?
No.
Well, it's interesting because there's a 71-page report here from the FTC. The study found that from internal documents and public comments that not only do PBMs reimburse their affiliate pharmacies at significantly higher cost than affiliated, but it also shows that PBMs use a number of tools to steer patients to their affiliated pharmacies, even when the cost is higher to the patient. And when discussing that matter, documents also show that they're more concerned about the optics of a patient paying thousands of dollars more than the actual patient paying thousands of dollars more. When you have independent pharmacists coming into our office in Congress repeatedly, and they say they're forced into using PBMs. So I'm assuming that you all know what a passive contract is. Mr. Joyner, do you know what a passive contract is?
It'd be helpful if you could describe it.
A passive contract is when a PBM sends a proposed contract to a pharmacy, for example, by fax, with a clause in it that says the pharmacy is in unless they opt out. And then they're automatically signed into the contract with the PBM. There may not even be confirmation that the proposed contract was received. Now, I find that to be unethical, but the FTC study showed that passive contracts make up a large percentage of the contracts sent out by the PBMs. So that's what I would say a passive contract is.
So, yes.
Okay. Dr. Costner?
Sir, you're asking, am I aware of what a passive contract is, just to confirm?
Yes.
Yes.
So you are aware. Dr. Conway?
Yes, I'm aware of that term.
Okay. Dr. Conway, have you all done this where you're sending out unsolicited communications to pharmacies and saying if you don't respond, you're opted in, unless you opt out?
We do not participate in that type of contracting, and our independent pharmacy network has grown over the last several years, and we pay them more than retail pharmacies and actually pay non-affiliated pharmacies on average comparable or more than our affiliated pharmacies.
So would you say that if whether a pharmacy is owned by the same company as the PBM, is that a factor in determining reimbursement rates?
No, we pay affiliated and non-affiliated pharmacies comparable rates. Often our own affiliated pharmacies are actually the lowest cost options in the market, and at the end of the day, as described, the clients, employers, and others select the network that they want to provide to their employees.
I wish I had more time. Mr. Chairman, I yield back.
Thank you. Gentleman yields back. And before I yield to Ms. Brown, just want to remind the witnesses, you're under oath, and the statement about having a good relationship with pharmacists, with independent pharmacists, that's a bit of a stretch, according to dozens of pharmacists that have texted my phone when you all said that. So just want to remind everyone, you're in the crowd, obviously. Just remind you under oath. And the witness that testified yesterday, things didn't turn out well for her over the past 24 hours. This is a serious issue. There's clearly a problem with the independent pharmacies and the PBM. And to characterize it that you have a great relationship, I believe is a stretch. That's my opinion. But Chair now recognizes Ms. Brown from Ohio.
Thank you, Mr. Chairman, and thank you for reminding our witnesses they are under oath. Our three witnesses, the executives of top 3 pharmacy benefit managers, control 80% of the market share in the industry. 80%. Over 270 million Americans have their drug prices in some way controlled or affected by these 3 companies sitting before us today. And yet, these companies have failed to communicate as to how they are working to lower the cost of prescription drugs, pass along savings to patients, and protect local and independent pharmacies. Members of Congress from both parties have expressed concerns about PBMs dictating requirements to local, independent, and small pharmacies, compelling them into your networks, and to accept the terms or be excluded from this crucial market. Unfortunately, many pharmacies cite untenable contract terms from PBMs as part of the reason they must close. Experts project nearly 1/3 of all independent pharmacies will be forced to close by the end of this calendar year. And approximately 2,200 retail pharmacies closed their doors in the last 4 years, many of which are in low-income or rural parts of the country where access is already a major issue. So I just want to get some clarity. If you do not agree that consolidation among the pharmaceutical industry is a key factor towards these closures, then in your opinion, what is the cause? Any of you can feel free to jump in.
So, Congresswoman, the data that I have shows a bit different of a picture around independent pharmacies and independent pharmacists. And our data would show that in the last 5 years, within our own network, I can't speak to others, that we've actually seen a net increase of about 20% of independent pharmacies open, net increase, and in the last year, 1,400 net increase.
Anyone else care to dispute this accusation claim with alternative facts, perhaps? Well, thank you. Would you share the same insight as it relates to local pharmacies rather than independent
So would characterize independent and local as being similar. So we only track independent pharmacies, of which they make up 1/3 of our pharmacy network and account for over 21,000 pharmacies across the country.
Similar but not the same. Reclaiming my time. Thank you. Many people, especially in vulnerable populations, rely on local and independent pharmacies, similar but not the same, for their medications and important health services. However, PBMs are forcing more and more people to specialty pharmacies or mail order pharmacies, which are owned by the same parent company as PBMs. As one example, PBMs can tell patients they can only receive an extended supply of their medication if they go to a specific pharmacy owned by the same parent company as the PBM, generating even greater profit for these giant pharma corporations. So I'm just going to dovetail into what my colleague talked about on the other side of the aisle. How do you respond to the accusations that you are steering patients to pharmacies owned by your parent companies? Hello?
So we have over 26,000 independent local pharmacies in our network. The reimbursement rate, the volume of prescriptions has gone up over time, and the number of pharmacies have gone up over time, and agree with you on the importance of these pharmacies.
So,
Anyone else with an actual answer?
So we do not steer. Our clients make the decision on which pharmacies they decide to put into their network. And our data would show that in the last year, mass retailers saw a 6% increase in pharmacy prescriptions. In the last 5 years, grocers saw an increase of 23%, while in the last year, our home delivery pharmacy had a relatively flat volume.
Thank you. I would again reiterate what our chairman talked about at the top of my remarks, is how critical this issue is and how important it is for you to be truthful, because Americans deserve an affordable and accessible health care. When a local pharmacy closes its doors, residents lose access to the pharmacy they know well. And when the only pharmacy in a community closes, patients are forced to travel further to get medications they need, potentially delaying their treatment and care. It is unacceptable to me that PBM practices would harm communities in this way. And with that, Mr. Chairman, I yield back. Thank you for indulging me.
Gentlelady yields back. Chair now recognizes Mr. Fry from South Carolina.
Thank you, Mr. Chairman. I think oversight's turning over a new leaf in 2 hearings in 2 days and wide bipartisan support. What do you think about that, Mr. Raskin? I think it's good. You know, what's interesting, for years, PBMs have quietly assumed control of a major facet of America's pharmaceutical industry through vertical integration and consolidation and methods like spread pricing. Major PBMs have been able to take control of prescription drug access, leaving little room for transparency in an industry where the sole mission should be to provide essential and life-saving pharmaceuticals to patients. This sort of control has caused an almost irreversible strain on America's independent pharmacies, one's in my district, one in the ranking member's district, one in the chairman's district, and all across this country. An illustration of that fact, the National Community Pharmacists Association, which represents over 19,000 pharmacies, cites that we can expect 1 pharmacy closure each day in the United States. I have heard from pharmacies within my district that it is often it is cost prohibitive to obtain the drugs and dispense them, and so they just choose not to. That they make their money or their profit on other things that they sell, like milkshakes or T-shirts or whatever it is in their particular pharmacy. It's kind of alarming. So for me, I think we start at the beginning. To what extent you each that are here today, you each have lawyers on your team that review contracts, is that correct? And draft contract language, is that correct? Yes or no? Yes?
Correct?
Yes.
Yes.
How much opportunity exists for a small mom and pop pharmacy in a rural area to negotiate their own contract? Is it a boilerplate contract? Do they have any negotiating room at all? Say I own my own pharmacy.
We are always open, Congressman, to negotiating with pharmacies.
How does that look?
Pharmacies can always redline a contract.
Do they?
To us and negotiate.
Do they?
They do.
How often?
I don't know.
How often do you
percentage.
actually negotiate with them?
As I said, I don't know an exact percentage. We have over 64,000 pharmacies in our network today, so it's a broad number, and there's a lot of volume that goes through.
Okay. So would you say, I mean, just to guess, would you say it's 20% of the time?
I wouldn't want to speculate, sir. We could get back to you.
I just find it deeply troubling that I actually don't believe you. And I'm curious if you have information on that. I'd love to see it. I don't think that they actually have any negotiating power whatsoever. That's what we've heard. So how would you, there's a wide gulf right now between what you're saying and what I have heard privately. So what's the disparity there?
Congressman, we're happy to engage and do engage with independent pharmacies. We have through the new initiative that we kicked off last year. It engages with over 3 dozen independent pharmacy owners that we convene. We meet with them on how we can work better together. We've had productive discussions in those meetings and are finding paths forward. It's around improving patient access to care and around providing additional services in those underserved communities in urban and rural areas. That's what we're focused on right now. And then improving reimbursement in some areas where access to care is really important. We've done that for over 700 independent pharmacies across this country.
What exactly is the goal with community pharmacy contracts that contain rates and terms that you know are below acquisition cost of the pharmacies? And in these, in my opinion, unacceptable contracts, if they're not, are they intended to force out competition? What is the goal of that? We've heard that a lot from independent pharmacies.
Sir, we're not focused on putting pharmacies out of business at all. And as I've said, our data actually is very different. We've had a net increase of 1,400 independent pharmacies in our network in the last year alone. So we're continuing to work hard with them to find those paths forward for patients to have broad access to care, whether it's an independent pharmacy, a grocer, or some other type of mass retailer.
What about the other two on this panel that have been pretty quiet? What do you have to say about that? That pharmacists are at a competitive disadvantage and that often receive below the rates and terms are below what the acquisition cost is.
Yeah, so Congressman, we have more than 27,000 pharmacies that effectively equals 40% of our network are independent pharmacies today. As we've said earlier in the testimony, we do reimburse these pharmacies at a much higher rate. In fact, upwards of 25% more for generics. If you were to apply that just across our commercial book, we've effectively paid independent pharmacies $340 million more than the equivalent chain pharmacies.
Mr. Conway?
We also have a similar number of independent local pharmacies, and also the volume of prescriptions in pharmacies in the network has continued to go up over time. We also have programs where we'll pay them for particular services as options.
I'm going to wrap up here, Mr. Chairman, just 1 second. In our first hearing, we heard about TRICARE, reimbursement of a medical facility or a pharmacy right outside of a base, and that it was cost prohibitive for them to care for our nation's men and women in uniform. And so part of this was because the cost did not justify keeping or continuing to serve that population. So I would invite you, that you're all here, you've heard the bipartisan support here, that y'all need to do more to work with these independent pharmacies because they're closing at a rapid rate and they're getting sucker punched every single day because of competitive disadvantages that y'all place in the marketplace. Thank you.
Gentleman time's expired. Chair recognizes Ms. Stansberry from New Mexico.
Thank you, Mr. Chairman. Gentlemen, thank you so much for being here today. I know you've taken a beating already for many hours this morning. I'm not a healthcare policy specialist. I'm not a prescription drug specialist. I'm just a New Mexican. And what I know is our healthcare system is terribly broken. In New Mexico, we have families that still do not have access to health care, people who are waiting in waiting rooms at hospitals who can't get emergency care. We have people who still do not have health insurance in spite of the expansions that we've had through the Inflation Reduction Act and, of course, the Affordable Care Act. And we still have people who are dying of unnecessary diseases because they cannot afford life-saving care and prescription drugs. So for me, this is really about the humanity of our health policy, and that's why I believe healthcare is a human right. And that is why I believe and support holistic and systemic reforms to our healthcare system, because we shouldn't have to have hearings like the hearing we're having here today. It should not be so complicated that, you know, one of our grandparents can't afford to get the life-saving medication that will keep them alive and healthy for the coming years. And it shouldn't have to come to the reality that we have private for-profit companies who have figured out how to game the system so that they can generate profits while providing some sort of service for their clients at the expense of our communities. So, you know, Dr. Conway, we had the opportunity to meet yesterday in my office, and I really did appreciate you stopping by. And one of the comments that you made in the conversation that we had is that, well, the prescription drug companies need to lower their costs. You know, the middlemen are just sort of taking advantage of the system as it exists. You didn't say that, I said that. But I think what this hearing really points to is a bigger problem, a sickness in our healthcare system. And the fact that private for-profit companies are able to profit at the expense of our communities, even if you are providing a service within that ecosystem. And, you know, a lot of my colleagues today have alluded to the Inflation Reduction Act. And I just want to emphasize that part of why it was so significant is it was one of the first times that we passed federal legislation that enabled our federal healthcare provider networks to negotiate prescription drug costs, just like you do as middlemen for your clients, so that our seniors could actually access affordable prescription drugs. And we know it's going to save people money. We know it's going to save lives, but there's still millions of Americans who can't afford medication. And I understand that these PBMs provide rebates. My mother was in the hospital a year ago, and when she was being discharged, she was told that the medication she needed for her heart condition was going to cost $400 a day. She was given a rebate. I think in these kind of policy discussions, the humanity gets lost. And, you know, these companies are taking advantage of a system that's not set up for our communities. So I think, you know, the one question that I would ask of each of you is just a very simple question, which is, do you believe that our system needs systemic reform? Do you believe that drug prices should be reduced? And would you support that, and would your company support that, even if it meant that you couldn't benefit and profit off of it? And why don't we start with Mr. Joyner?
Congresswoman, thanks for your comments, and completely agree with you. I retired at the end of 2019. I came back a year and a half ago for the very specific reason that you mentioned, which is I want to be a part of changing the healthcare system in this country. In large part, we've been successful in doing, at least within the last year. We introduced a biosimilar into the market with a low list price.
Thank you, Dr.
Delivered savings to the members at zero out of pocket, and 50% cost reductions for our employers. So I think we're making headway, and especially with the new price model, to solve exactly what you're referencing.
Thank you, Dr. Kotzner.
Congresswoman, there's always more that we can do, and you do point out some challenges that our healthcare system certainly has. We believe within the commercial market, we can move swiftly to be able to make lower cost products available to patients. Certainly there's always more
Thank you,
that can be done.
Dr. Kotzner. Dr. Conway.
First, appreciated meeting yesterday. We at United Health Group do think the health system needs to perform better for everyone. And as I said yesterday, we believe list prices of pharmaceuticals as set by manufacturers should come down in the United States.
Thank you. And I did not mean to interject, gentlemen, but this is not a hearing for advertising our companies. This is really about addressing the healthcare crisis that our communities are facing. And I appreciate the role that you're playing, but we've got to reform the system because there are people dying in this country who shouldn't be because they can't access medicine. And with that, I yield back.
Chair now recognizes Mr. Langworthy from New York.
Thank you very much, Mr. Chairman. I really appreciate you bringing this hearing forward, and I thank you all for being here today to discuss this important topic for Americans of all ages and across all communities. Employers, unions, and even state governments that sponsor self-insured health plans for their workers are considered fiduciaries under federal law. They must make decisions that keep health plan costs low and that are in the best interests of patients. Now, currently, PBMs are not held to the same standard that applies to plan sponsors, despite essentially standing in the shoes of the plan sponsor when performing pharmacy benefit plan design and management services on their behalf. As a result, PBMs continue to charge unreasonable and excessive fees, steer plan participants to higher costing prescription drugs, and pocket rebates and discounts that should belong to the plan. These actions are not in the best interest of participants and are not what the plan sponsors would do, much less could do, given their fiduciary duty to the plan. Mr. Joyner, can you tell me why you think PBM should not be a fiduciary?
Congressman, the role of the PBM is to serve the customer or the clients that are managing the pharmacy benefits. So we do not have control over the benefit design that actually passes through to the member.
So it sounds like PBMs do not want to help. They don't want to be plan fiduciaries because there are certain things that they do or want to do which fiduciaries would not be permitted to do. Can you give me some examples and ways in which PBM's hands might be tied if they were a plan fiduciary?
A good example, and I use the new price model that we're rolling out. Today, we pass through 99+% of the rebates to our customers, and our customers then determine how best to use those discounts in terms of reducing either the premiums and or reducing the cost of the drugs. In true cost, we're looking to incorporate those discounts so that it passes through to the actual member and getting the client alignment so that it aligns both the client and the employee experience.
Do you think that PBMs are making decisions that help keep plan costs low, or are they helping plan sponsors be good stewards of benefits?
Our first goal is to reduce and manage the overall cost of pharmacy. And then ultimately that allows our customers to become good stewards of their benefits.
What about when Johnson & Johnson's PBM charged patients over $10,000 for a $28 drug?
I'm not familiar with that.
How about when PBMs refuse to give patients access to much cheaper alternatives to expensive drugs like Humira?
So, Congressman, using the Humira example, we actually took Humira off of our formulary in April of this year. We converted 97% of the medications into a lower cost biosimilar. Our clients, plan sponsors, saved $500 million as a result of that change, 50% reduction off of what they were spending in 2022. And importantly, the employees, for the most part, paid $0 out of pocket for that biosimilar.
So it sounds like PBMs believe that they're currently doing their best to keep costs low and act in the interest of the patient. If that is the case, you're already complying with fiduciary standards, so why are PBMs so dead set against being fiduciaries?
Again, as I mentioned, we do not have control over the benefit design. The clients, the employers, which is an employer-funded healthcare system today, determine how they're going to ask members to participate from a premium or contribution, and ultimately designing the out-of-pocket costs for their employees. We facilitate that, but we do not make the decisions on behalf of our customer.
Will your company commit to supporting fiduciary standards for PBMs?
We certainly support complying with the contracts that we have with our customers. And again, our contract is to make sure that we're delivering the lowest net cost and managing the overall pharmacy cost for our customers.
I think there's a reason PBMs don't want to be fiduciaries. In my remaining time, I'd like to pivot and discuss a recent court ruling that CVS Caremark was involved in. Last year, an arbitration panel required CVS Caremark to pay over $20 million to just one oncology practice, New York Cancer and Blood Specialist, for miscalculating these fees. In essence, the company charged higher fees when an oncologist did the right thing by stopping an oral cancer drug that was not working and had side effects. CVS Caremark clearly stood in the way of properly treating cancer patients. Mr. Joyner, CVS Caremark fought to hide this award and not pay it vigorously, suing the oncology practice. However, last week, the New York Southern District Federal Court ruled in favor of the practice and ordered CVS Caremark to pay over $20 million in back DIR fees, interest, and attorney's fees. I enter that ruling into the record with unanimous consent, Mr. Chairman.
Without objection, so ordered.
I understand that other oncology practices are in arbitration right now with CVS Caremark over the same issue. Given the federal court's findings, do you intend to pay all practices back for a clear miscalculation of DIR fees, or do you intend to fight them like you did the New York practice?
Congressman, as I answered the question earlier today, we comply with all the Medicare Part D rules regarding network adequacy as it relates to also the DIR. So we have consistent and standard terms and conditions, and we fully expect to administer and support those for our customers.
Thank you very much. I yield back, Mr. Chairman.
Chair now recognizes Mr. Kassar from Texas.
Thank you, Chairman, and I'd like to commend the ranking member and yourself on having this bipartisan hearing. I'd like to see more of this and appreciate it. Today, we're discussing pharmacy benefit managers, or PBMs, which, as we've talked about today, are pretty opaque organizations that most Americans don't know very much about. But the three leaders of these PBMs today touch or interact with about 80% of the prescription drugs accessed by Americans. And the goal of PBMs is to negotiate down the prices of the medicine that we need. But this comes at a time when Americans indeed are paying more for prescription drugs. The 25 drugs with the highest Medicare spending have tripled in cost since entering the market. Between 2022 and 2023, 4,200 drugs have seen price increases, and our country still has the highest per capita prescription drug spending among developed nations. And so the goal that we have set for PBMs in this system, in my view, we are far from hitting that target. In fact, we're headed in the wrong directions. The three companies represented before us, though, are some of the most profitable companies in America. These three companies made a combined $400 billion in revenue and some $18 billion in profit in 2022. And so to me, I think one of the core questions we're trying to ask today is, if there is this much profit in this industry, where are the savings for everyday Americans? We've discussed, and I've heard from colleagues about how PBMs are connected to the same parent company as health insurance, which can limit patient choice. We've heard about how rebates, which are the savings negotiated by PBMs, could be raising the cost of drugs. And we've also heard how PBMs can shut out local pharmacies and drive profits towards pharmacies under their umbrellas. But I want to focus on a different issue, which is the question of group purchasing organizations, or GPOs. The three major PBMs have a GPO under their umbrella. If I'm right, I think CVS's is Zinc, Express Scripts is called Ascent, and Optimum RX's is called MSR Pharma Services. The goal, supposedly, is to leverage purchasing power to negotiate greater savings from pharmaceutical manufacturers, but these are relatively new practices. From each of the witnesses, a quick yes or no: each of your GPOs was founded in or after 2019. Is that correct, Mr. Joyner?
Correct.
Doctor?
Yes, that's correct.
Thank you.
Yes.
And my understanding is that before those GPOs were founded relatively recently, PBMs were negotiating without the separate company doing it on their behalf. And so the obvious question is, why do the PBMs need these new GPOs? According to New York Times reporting, a former Optum RX executive said the intention of the GPO is to create a fee structure that can be retained and not passed on to a client. And that's a big deal. If the value is getting discounts in prescriptions, but now we have these totally new companies, supposedly to create fees that then could not be passed along. In 2018, before any of the GPOs were founded, drug manufacturers paid $3.8 billion per year in fees to PBMs. By 2022, they're paying $7.6 billion in fees to PBMs and to their GPOs. So, again, just here for my last minute, the point is that PBMs are supposed to be reducing drug prices supposed to be reducing healthcare costs, but a 2022 study found that the average premium for individual health insurance has gone up $225. 2 in 5 adults on employer-sponsored insurance are having difficulty affording their medical care. So if people are paying more money, if the number of fees has nearly doubled here to $7.6 billion, then why aren't prices coming down? I guess my question to you, Dr. Conway, for example, would be, if these GPOs are generating this much more in fees, where is the value to the American people? Why is it that annual premiums continue to go up? Why is it that thousands of drugs have seen price increases while billions of dollars in new fees and profits are going to PBMs and to their GPOs? Dr. Conway, you can take it.
The purpose of the GPO is to negotiate rebates, larger discounts on our clients' behalf. As I said, many clients choose 100% of those rebates to pass through to them. And so we'll continue to work to make medicines more affordable and healthcare more affordable for the American people we serve.
But if, since you created these GPOs in 2019, we've gone from $3.8 billion in fees to $7.6 billion in fees, but we continue to see the price of drugs go up. How does that add up?
So the net prices of drugs, we continue to negotiate down. The list prices of drugs have gone up exponentially in the U.S., and those list prices are set by manufacturers.
Mr. Chairman, right before I yield back, I just think that it's, through all of the acronyms and all of the opaqueness we've been dealing with in this hearing, we continue to see the American people pay more and more. And once you take away all of the sort of shell games, people are paying more. There's more profit going both to big pharma and to the PBMs, and it's ultimately our constituents that are left paying the price. Thank you. I yield back.
Gentleman yields back. Chair recognizes Mr. Gosar from Arizona.
Mr. Chairman, I yield my time to you.
Thank you, Mr. Gosar. I appreciate it. In the past 5 years, the states and the federal government have begun enacting PBM reforms. Each of your companies or your parent companies created corporate entities in foreign countries, well known for their lack of financial transparency and low tax rates. Each of your companies has since begun shifting PBM duties, including negotiations with manufacturers to those foreign countries. In fact, Mr. Kotzner, Cigna Express Scripts created Ascent Health Solutions based in Switzerland to serve as a group purchasing organization negotiating rebates with manufacturers. Cigna Express Scripts also created Qualent Pharmaceuticals based in the Cayman Islands to buy cheap pharmaceuticals and sell them at a higher rate in the United States. Mr. Conway, United Health Group's Optum RX created Emissar Pharma Services based in Ireland to serve as a group purchasing organization negotiating rebates with manufacturers. Mr. Joyner, CVS Caremark created Cordavis based in Ireland to commercialize biosimilar products and resell them in the U.S. for higher prices. Your companies have created entities in foreign countries that appear to be for the specific purpose of avoiding U.S. regulation and avoiding U.S. taxes. This is simply not acceptable. But I'll give you each the opportunity to explain why those 3 countries, Ireland, Switzerland, and the Cayman Islands, were better locations for these companies than the United States. Mr. Joyner?
Mr. Chairman, Cordavis, which is located in Ireland, is in Europe close to where the drug is being manufactured today. So the whole premise of building an operation in Europe is to be close to where the drug is manufactured, so it helps with the logistics and the ability for us to bring the product into the U.S. And good news is the biosimilar that we brought to market was a lower list price product. It was 82% below the price of Humira. We were able to pull through as of April 1st, but by removing Humira from our formulary, we actually pulled 97% of all the biosimilars through for our customers, yielding $500 million worth of savings for our clients, and the employees and or the members of these firms actually paid $0 out of pocket for the medication. So it's actually a win-win for us all.
Dr. Kotzner?
So, Mr. Chairman, the creation of Ascent Health Services in Switzerland as a group purchasing organization is delivering more value because of the aggregation of additional entities that are also participants with Innocent Health Services, more than what Express Scripts could do on their own. GPOs have been used within healthcare for decades and have been shown to lower costs for clients and for patients ultimately.
Dr. Codway.
MSR is incorporated in the United States. It does have employees both in the United States and Ireland. And as stated by others, the purpose is to negotiate rebates and discounts on behalf of our clients, and we adhere to all laws and regulations and do that transparently.
Mr. Joyner, in your written testimony to the committee, you reference a new transparency program called True Cost. When did that program start?
Congressman, we announced it last year.
Have you piloted the program to determine if it actually enhances transparency?
We have. In fact, we have now rolled it out to our own employees effective June 1st and have a number of customers lined up as we enter the.
So when will it be fully implemented?
So our expectation is that it will be staged, but right now our hope is that we'll have a good portion of our business moved into 25 and ultimately into 26.
Dr. Constner, in your testimony, you referenced the Independent RX initiative that Express Scripts launched in spring 2023. What tangible benefits to independent and rural pharmacies has this program produced?
Mr. Chairman, we increased reimbursement to over 700 independent pharmacies out of our own pocket as part of this initiative. In addition, we convened an independent RX committee that we've met several times already with in person, 38 pharmacists, I believe, that are independent pharmacy owners to work on advancing the practice of pharmacy so that pharmacies can practice at the top of their, pharmacists can practice at the top of their license.
Has Independent RX increased reimbursement rates to independent and rural pharmacies?
It has to over 700 that have accepted the increased reimbursement that we're paying out of our own pocket.
Last question. You also referenced that the number of independent pharmacies in Express Scripts commercial network increased by 20% from 2019 to 2024. Does this include the 15,000 pharmacies dropped from the TRICARE retail pharmacy network in late 2022?
So our broadest network has 18,000 pharmacies roughly in 2019, which expanded to over 21,000 by 2024. That's the 20% increase. The TRICARE network, over 2/3 of the independent pharmacies in our network do participate in TRICARE, but it is less than the total.
Chair, and I recognize Ms. Presley from Massachusetts. And I want to thank the gentleman from Arizona for yielding his time. Chair, and I recognize Ms. Presley from Massachusetts.
Thank you. Discussion today speaks to an injustice that many of my constituents in the Massachusetts 7th experience daily, the high cost of life-saving prescription medication. Pharmacy benefit managers, or PBMs, play an outsized role in determining coverage and costs of medication by designing lists of drugs that a health insurance plan will never cover for a patient, known as formularies. For some medications, PBM formularies require additional approval before you, a patient, can pick them up at the pharmacy. For example, prior authorization is a PBM power where a doctor must ask the insurance company if they can prescribe a specific medication. And there's so-called step therapy that requires you to try a different medication and have a negative reaction before being prescribed the medication that your doctor recommends. These policies are hurting people across our nation, including in my district. One of my constituents, a mother, shared her story of how she was forced to go through a step therapy to treat her neurological condition and saw her condition worsen as a result, to the point where she spent a year relearning how to walk. And her story is no anomaly. Step therapy is not just ruining people's lives, it is killing them. Families have been robbed of their loved ones due to the delays, the greed, and harmful policies of PBMs. Mr. Joyner, CVS Caremark is one of the largest PBMs operating within my district. What do you say to my constituents who have been harmed by denying them the medical care that they need and deserve?
Congresswoman, I don't have the specific details of what you're referencing, but I certainly do understand and look specifically at ways in which we can improve the prior authorization process.
Are you sorry?
No, I think it's an important part of the healthcare system is to make sure that we're looking at, our customers hold us accountable and look for, make sure we have oversight for both patient safety. They're also focusing on ways in which we can improve adherence to the therapy, because if they're not staying on therapy, obviously,
Okay,
then there's a...
reclaiming my time. I wish you were sorry. You should be. I've not heard from a single doctor who can justify the public health benefits of the health insurance policies. According to the Federal Trade Commission, the committee is responsible for determining access to medication. Don't just consider clinical recommendations. PBEs also, quote, take into account business considerations and make formulary determinations to maximize profit. I will remind the witnesses that you are all under oath. My next questions will be yes or no. Mr. Costner, does Express Scripts factor in business considerations or potential profits when deciding access to prescribed medication? Yes or no? And again, you're under oath.
Thank you for the question, Congresswoman. We do a clinical first approach. So all clinical evaluation is done first.
Yes or no?
Then a financial evaluation is done after that.
Yes. Yes or no? For the record.
Financial evaluation is included after the clinical.
Mr. Joyner, does CVS Caremark factor in business considerations or potential profits when deciding access to prescribed medication? Yes or no?
Congresswoman, we have a Pharmacy and Therapeutics Committee that assesses the clinical value of the medication.
You all are very smart. Can you just answer the question, yes or no?
Like I said, we have a P&T committee that assesses the clinical...
Reclaiming my time. Dr. Conway, does Optum prescription factor in business considerations or potential profits when deciding access to prescribed medications? Let's see if 3 will be the charm. Yes or no?
Clinical consideration, then lowest net cost to the customer, including a formulary exception process.
Reclaiming my time. Well, my office has met with patients, families, providers, and community pharmacists throughout my district, from East Boston to Cambridge to Roxbury, and they all point to one conclusion. You are putting profits over people. Your corporations are denying people access to necessary medications, preventing them from going elsewhere by forcing independent pharmacies to close their doors. And that is why I am glad we're having today's hearing to shine a bright light on your unethical practices, and I look forward to working to Congress to rein in PBMs. Thank you, and I yield back.
Gentlelady yields back. Chair now recognizes Mr. Biggs from Arizona.
Thank you, Mr. Chairman. I associate myself with many of the comments of Representative Kassar from Texas, and nobody will be more surprised than he. But it's true. I thought he did a nice job. Mr. Costner, I want to focus on active service members who are insured through TRICARE. The Department of Defense just renewed their exclusive contract with Express Scripts. Is that correct?
That's correct.
It's my understanding that as part of this renewal, in October of 2022, 15,000 independent pharmacies were removed from the TRICARE network. Were these pharmacies priced out, or did Cigna negotiate the removal from the network as a condition of renewal of the contract?
So, Congressman, all independent pharmacies had the opportunity to continue to participate in the network, and they made a decision not to. We've subsequently opened back up their opportunity to participate should they want to.
How many came back?
So right now, 2/3 of the independent pharmacies in our total broadest network participate in the TRICARE network, and in total...
I'm sorry, I don't want to be pushy, but when you say 2/3 of this or that, it doesn't do me any good. I want to know how many. What's the actual number?
So roughly, if we have a network that has over 21,000 pharmacies in total, independent pharmacies in our network, 2/3 of those roughly are participating in the TRICARE network.
So 14,000. Is that what you're telling me? 2/3 of 21,000 is 14,000, right?
It's an approximation, but it's in that area.
Did those pharmacies return in 2023 after the renegotiations?
We continue to keep that open, so any pharmacies that want to choose to participate have the ability to.
How many of those came back after the renegotiation in 2023? Look, I'm not playing gotcha. I just really want to know, okay?
I don't have that information in front of me today, sir. We could certainly provide it, though.
Yeah, Mr. Chairman, I want to introduce to unanimous consent. I always have articles, as you know.
Yeah.
Entitled 1, Prescription Drug Middleman Potentially Profiting Off Veterans, and TRICARE remove 15,000 independent pharmacies from network into the record.
Without objection, so ordered.
Thank you. I have serious concerns about how the situation looks. What is the justification for limiting choice and access to medication for service members, Dr. Kotzner?
So, Congressman, we continue to exceed the access standards that are set by TRICARE, which ultimately are set by Congress for patients. 98% of patients that are TRICARE beneficiaries live within 15 minutes of a pharmacy that's in their network today.
It's my understanding that you're a vertically integrated corporation. Is that right?
The Cigna Group has multiple different companies, if that's what you're referring to from vertical integration.
Yeah, yeah. I think you know what vertical integration is. Do you ever steer patients, including service members, to your own pharmacies or to use mail order? Do you ever, in other words, do you ever steer consumers to your preference as opposed to necessarily their preference?
Congressman, we carry out the benefit as directed by TRICARE, and
So-
TRICARE makes the decision on which pharmacies they want to have in their network and prefer.
So I'm going to ask that question again because you seem like a nice guy. You seem bright. So I think you can answer this question. Do you guys ever engage in steering patients to your preferred service provider?
Congressman, so if we're specifically speaking of TRICARE,
Yes.
TRICARE makes the decision on whether they want to prefer a pharmacy or not. So in this instance, TRICARE does have our home delivery pharmacy as an option as a preferred pharmacy.
Thank you. Mr. Chairman, I'm going to run out of time, so I'm going to just give you some more of these as well. So I think we did that one and that one. There we go. Mail order medication is often exposed to unsafe temperature, study says. 90-day prescription isn't for everyone. How chaos at chain pharmacies is putting patients at risk. Independent pharmacies continue to face financial hardships as the clock ticks on PBM reform. America's pharmacy deserts.
Without objection, all those articles will be entered into the record.
Thank you, Mr. Chairman. Yield back.
Chair now recognizes Ms. Tlaib from Michigan.
Thank you, Chairman Comer. Chairman, I do want to help support all the text messages you got. I actually got letters of independent pharmacists who say they do not have great relationships with their PBM. One is from independent pharmacists in Flint, Michigan, another who owns a number of independent pharmacies in the Upper Peninsula in Michigan.
Without objection, so ordered.
Each of you have noticed, have said that you have business plans or processes and methods in place to help lower cost for our residents. Yet it has been well documented there has been a huge reduction of pharmacies in many vulnerable areas. I do have really just question, and it is really a yes or no, and I promise, like, you should know this, but did you all make more money in this year than you, I mean, like in 2023 than you did in 2022? Like profit. Did you make more money, Junior? Did you guys make more money? Are your profits going up, yes or no? Is it?
In 2024, my profits are going down from 23.
It's going down right now?
Yeah.
You're not making any money?
No, we are making money. I'm just
But
saying if
it's
you're
down
talking
from
about the growth.
2023?
Yes.
Interesting. How about you, Kastner? Katzner, is that how you say it?
Yes. So the Cigna Group's profits, as we report, did increase from 22 into 23 and for the first quarter of 24.
So you're doing good. Okay, how about you?
Yes, OptumRx earnings increased from 22 to 23.
By a lot? Is it like doing really well? I don't understand how you're making money and making profit if you're trying to lower costs on our residents. I'm just confused how you can do both. I know my colleagues are not going to get into it, but how do you do both when you got to be making money from somewhere? if it continues to increase. So one of the things that I know, are, of course, the DIR fees and reimbursement. But one of the things in the report, and I know you all saw it, but in there, it talks about the post-sale adjustments. Get this, Chairwoman, and Chairwoman McLean and I come from the same state. But check this out. Post-sale adjustments can require a pharmacy to often blindly make payments of hundreds of thousands of dollars back to PBMs months after the relevant prescriptions are sold. So this is like one of my residents going in and they buy $5 worth, I don't know, dairy products or something like that. Like I think I used the example of a gallon of milk. Goes in, buys a gallon of milk, later sees a charge of $5 extra, like after they left the grocery store. So quoted in the report, it says we're often talking about PBMs charging hundreds of thousands of dollars. These are not small fees, though. So the FTC report noted that one of the metrics PBMs often use is, it's really interesting, deciding whether or not to charge pharmacies retroactive fees. These are, again, they left, they paid for it, you all came back and charged them more. It's crazy. Is adherence to medication. I kid you not, Chairwoman. It says, but there's many reasons. So they say that basically the post-sale adjustment is based on whether or not they're punishing them because a patient is unable to afford their medication, or when the patient cannot pick up the medication on time, that they have an unpredictable work schedule or something, whatever it is. It's some weird little factor you guys are putting in reasons that might all of a sudden say, well, we got a post-sale adjustment. How many of you use post-sale adjustments? Mark, you guys use post-sale adjustments?
No, that program discontinued in 2023.
How about you, Katzman?
Congresswoman, we don't engage in clawbacks.
Yeah, how about you?
OptumRx does not do clawbacks or charge DIR fees.
So what is this thing about you all doing the thing about using to determine whether or not to charge pharmacies, whether or not, how removing like the patient adherence? How many of you use that factor? If the patient adheres, how many of you? Katzner, you look like you're interested in this question.
So, Congresswoman, the DIR program expired last year. So that's
so.
Not
But do you at all determine post-sale adjustments or anything? You don't do any of that anymore.
We don't engage in clawbacks.
Okay, you call clawbacks. Is that what you guys call clawbacks? Post-sale, like you add. So if any of your independent pharmacies, they walk out and you guys don't go back and say, oops, you owe another $10. None of you do that?
That's not a practice that we're engaged in.
Okay. What is this about a factor using a patient adherence from factors being used to determine whether or not, like, what is that about? Like, the patient is using it. I'm being serious, you guys. This is something in the FTC report, so I'm just curious. Did you guys stop it because they caught you, or what's going on here? Or you guys changed the name of it?
So that was the DIR program was actually removed from, it was a government decision. It wasn't a decision that
we forced you guys to do it?
It was enacted by
Yeah, we forced you to do it. What else should we be forcing you guys to do? Because it's still, I'm being serious. You know that you're in the practice, if you're making profits continually, it's not reducing the cost on our residents. Something's wrong. And when I hear from independent pharmacy, I mean, you hear this. I had one in my district, Chairwoman, last thing. He paid like $100 or something right out of pocket. He never got reimbursed for it, ever. He said, because again, whatever you all are doing, it's putting them out of business. And guess what? That means less access to our residents that really depend on independent pharmacies. But again, it sounds like we need to do some forcing them to act in good faith. Sounds like we doing the DRA. If we stop those programs, what else do we need to stop so they can treat everybody fairly and not monopolize as well? I know you guys do that and you don't offer everybody the same service, and that's ridiculous. With that, I yield.
Thank you, and I now recognize myself for 5 minutes. I think part of one of the biggest issues we have is the pharmacists think there's a problem. The patients who use the services think there's a problem. I'm curious to see, do you all think there's a problem with the PBMs? Mr. Joyner?
As I mentioned, Congresswoman, as I mentioned in my opening statement, I do believe that there is an opportunity to improve.
So is that a yes? Because the reason why I ask is because we can't fix a problem that we don't think exists. Yes, there's an opportunity to improve. I'm asking you, do you think there's an issue? Do you think there's a problem? Because perception's 90% of reality. And the user thinks there's a problem. The pharmacist thinks there's a problem. I'm wondering if you think there's a problem.
I absolutely believe that there's an opportunity to solve.
So is that a yes?
True cost.
Is that a yes?
So the answer
Okay,
is
never mind. How about you, Dr. Kutzner? Do you think there's a problem that we have an opportunity to fix?
Congresswoman, healthcare is hard, so agree that there are challenges and continued issues that we can all do better on, and we certainly can be part of that solution.
Okay, I'm going to ask it one more time before my patients get. Do you think there's a problem?
Congresswoman, there are always challenges within healthcare,
Okay.
and so we always.
I'll reclaim my time. Dr. Conway.
Yes, as a practicing physician, medicines need to be a full.
Hallelujah. Do you gentlemen see how he answered that question? Yes, there's a problem. We might be able to get to some solutions. And I think therein lies the problem. You all are the middlemen. You all want to make a profit, which, okay, that's good. But if you're not delivering an outcome to the people who use it, how long do you all think you're going to have a job? There's a problem. We got to fix it, right? And part of the issue is prescription drug prices have increased every single year for the past 15 years. And the so-called middlemen in the drug market, the PBMs, clearly have the ability to impact that cost. I mean, I might remind everybody, the reason why we put this program together was to help reduce costs. Am I inaccurate on that? It seems to have done the opposite. Yet the most concerning thing to me is I continue to ask you all when you come into my office, because you seem to think that there's not an issue, except for you, Dr. Conway, and I appreciate that, is show me the data that supports your position, right? Just show me the data, because the other side that thinks there's a problem, the end user, has the data, right? My colleague from Michigan has testimony from our constituents telling us that there's a problem. They have this little thing called data. When I ask you all for data, ad nauseum, I might say, you send me a really pretty PowerPoint, of which I'd like to enter into the record, which is a sales piece. I spent 35 years in sales. This isn't data. So I'm going to ask before we go on, do you have, and if you don't, that's okay, perhaps that's where you should start. Do you have specific data, not a pitch book, but do you have specific data that you could share with me and the members of this committee that shows you actually are doing what the PBMs were supposed to do, and that saved costs for the patient? Do you have specific data that you will actually send to me, Mr. Joyner?
Absolutely, we will send you.
And when could I expect that?
I will work with my staff and get it to you ASAP.
ASAP as in Monday, perhaps?
I will work with my staff.
That's great. ASAP as in 2 months from now? ASAP is in 2 years from now, of which I've been asking?
Yeah.
ASAP just is like ASAP.
No, we do.
Okay, I'll pay you as soon as I can pay you too. Don't you worry. I'll get you your profits as soon as ASAP, yeah? I can't define ASAP, but, like ASAP. How about you, Mr. Kutzner? When can I expect this data? Not the pitch book.
You to review the written testimony that we submitted. It's a lengthy testimony, and it is full of data and stats of the good work that we do. I'd be happy to follow up on any additional stats.
Good. Let's book a meeting with you and I. I would be more than happy, okay? I would enjoy that, because therein lies your problem, is you all don't think you have a problem. And I've been asking ad nauseum for data and you shuck and jive. Oh, look over here. Oh, it's not really happening. Oh, it's 2/3. Well, I'm not really sure how much 2/3 is. I mean, people are having problems. You want zero transparency. I can see why. It's like we're trying to help you. One side is saying they're hurting. The American people who pay costs are hurting. Yet you don't have any data to show us. It's very, very frustrating. And I'll just share with you where this is going to end. This is going to end at the PBMs being out of business, and the only people you have to blame for that is yourself. And with that, I'm over. I'll yield back. The chair now recognizes Mr. Frost for 5 minutes.
Thank you so much, Madam Chair. Patients are paying hundreds of dollars for extra drugs thanks to Big Pharma and PBMs. PBMs are claiming that they are lowering medication costs, but for many drugs, they are not. PBMs, y'all are doing dirty deals, conspiring with Big Pharma to drive up drug prices. Big Pharma says to PBMs, agree to recommend expensive brand name drugs to healthcare plans, and we will give you better rebates, like a recent FTC investigation brought up. For example, Mr. Kotzner, your PBM only suggests brand name drugs that treat hepatitis C, even though cheaper generic alternatives exist, according to a recent New York Times article. Mr. Kotzner, has Express Scripts, your company, ever entered into a rebate agreement that requires Express Scripts to cover a brand name medication instead of a generic one?
So, Congressman, in terms of first hepatitis C, we led the charge on that a decade ago and saved our clients $1 billion and saved American healthcare $4 billion.
But is it yes or no on the question I asked? Has your company entered into rebate agreements that require your company to cover brand medication instead of generic ones?
So
yes or no?
there are times when we will prefer a brand generic over a brand product over a generic when there's limited generic competition, and the lowest net cost is the brand's actually cheaper. And we actually are able to put in our system so the patient pays the generic co-payment or the generic co-insurance, so the patient is not harmed in those situations, and our clients actually save. The reason they save is because brand manufacturers contract and prevent generics from entering the market, and when you have limited competition, sometimes a brand actually can be
reclaiming
cheaper.
my time. So the answer is yes, you have entered into rebate agreements with these companies to push a brand medication instead of generic. You're saying that there's cost savings, but patients still have to pay more since the co-pays are usually higher for the brand name drugs versus the generics. When PBMs aren't doing dirty deals and they do suggest generic drugs to healthcare plans, they've been known to charge massive markups. One example, Mr. Joyner, your PBM charged some healthcare plans $138,000 a year for a generic cancer drug that actually has a wholesale cost of just $14,000 a year, according to a recent New York Times article. That's an 885% increase in price. Mr. Joyner, the cost of that greed is passed directly on to ordinary people. Will you commit right now to lowering the cost of generic medications like this one on your formularities?
So, Mr. Congressman, we have committed, and I've mentioned in my opening testimony, that we are introducing a new price model by the name of True Cost, and we are committed to lowering the cost of both brands and generics for members.
That's good. That's good. So can you commit right now that the current increase on that is 885%? Can you at least commit to not going higher than 885% of a markup on your generic medication?
So if you look at True Cost,
is it yes or no? Would you be able to do it with True Costs? Make sure this happens?
Absolutely. True Cost, which is our new innovation and what we believe is changing the marketplace.
That's good. So because of True Cost, we can confirm today that at least the medication will be marked up 885%.
No, that's not
No,
accurate.
so it could go over 885%.
So True Cost allows us to get to the acquisition cost of the product, which is
Mr. Joyner, I'm sorry, just a yes or no. So are you saying no, it can't?
On to the member.
It could be 885% of a markup on a generic medication?
No,
No?
way in
Now it's
which-
no?
The way in which the true cost price model will work is that we'll take 14,000.
Okay, I'm going to move on because I have limited time, but it was a simple yes or no. I thought it was a yes, then you went back to no. It seems like no, you can't say that you won't be having an 885% markup on generic medications. PBMs and pharma are both to blame for these high drug prices. You guys love to point fingers at each other, but this won't work. We're holding both of you accountable. I know you like to talk about this 6% number. PBMs will talk about how they take home just 6% of the cost plans, and patients pay for prescription drugs while pharma takes 64%. But that just tells part of the story, because that 6% number, that statistic, comes from the cost of drugs you can't even negotiate for. PBM's real cut of the profit is much higher when you look at the drugs that you touch. I'm just curious, Dr. Conway, what was your salary this last year?
My salary last year was a little north of $4 million.
Dr. Kotzner?
Sir, I'd be happy to provide that offline.
Why can't you provide it now? I just got it from Dr. Conway.
Our company does publish.
Okay,
the
moving on. You don't want to
five
say it, Mr. Joyner?
I just came back to the company, so I'm now in my first year.
What are you supposed to
and a
get
half.
this year?
I will follow up with you offline.
Follow up offline. This is the issue. I know I'm over time, but it doesn't matter if you're Democrat or Republican. This is a crisis in this country. People are dying because they can't afford their medication, and you all are part of the problem. I yield back.
Chair now recognizes Ms. Miller Meeks from Iowa.
Thank you very much, Mr. Chairman, for allowing me to weigh in to this critically important hearing. And thank you for moving my cost-saving PBM reform legislation, the Drug Act, favorably through your committee earlier this year. Let me also just add on to what my colleague just said, and who's responsible for high prices in prescription drugs. And I'm going to add that government is also responsible for that in some of the legislation that we put forward. It's no secret that PBM middlemen artificially inflate the cost of and limit access to prescription drugs. My first attempt at PBM reform was as a state senator when I passed a bill in 2019 trying to get at transparency of this marketplace. This occurs at the expense of patients who receive health insurance in public and private markets and impacts patients of all ages. The PBM market has become highly consolidated, with the three largest PBMs controlling roughly 80% of prescriptions. The top 6 PBMs account for 97%, and in Medicare Part D, 4 PBMs manage benefits for a combined 90% of beneficiaries. PBMs claim that they reduce drug prices by holding pharmaceutical companies accountable. This is done by requiring rebates on drugs, which are then passed on to the beneficiary. But is that beneficiary the patient? While PBMs often do negotiate discounts from manufacturers, patients are not the ones who benefit from them. In Medicare Part D, for example, patient cost sharing is based off the list price of drugs, which are artificially inflated by the PBMs to extract a higher rebate. As a result of these practices, for 79 of the 100 most rebated drugs in Medicare Part D, beneficiaries pay more for the drug than their insurer, again demonstrating that beneficiaries, in this case seniors, are not benefiting from rebates. This is why I led the bipartisan Share the Savings with Seniors Act, which would require full rebate pass-through for chronic care drugs covered under Medicare Part D plans. Another way PBMs cut cost at the patient's expense is by limiting the number of treatments available on formularies, despite claims by PBMs that they promote access. In 2022, 1,156 medications were excluded from at least one of the 3 PBMs, CVS, Caremark, Optum, RX, and Express Scripts, from their formularies, which represented a 961% increase in excluded products from 2014. This is not a partisan issue. Every American who utilizes prescription medications experiences the impact that PBMs and vertical integration have on our healthcare system. And let me also say that my mother had Express Scripts. And for me, there are some benefits that PBMs actually help to provide. However, this is partially why, and this is why that the Federal Trade Commission, because of this vertical integration, which currently comprises our Federal Trade Commission more Democrats than Republicans, is investigating the harmful impacts of middlemen and the vertical integration. Chair Khan of the FTC stated in recent interim report that dominant pharmacy benefit managers can hike the cost of drugs, including overcharging patients for cancer drugs, and that PBMs can squeeze independent pharmacies of many Americans, especially those in rural communities that depend on essential care. In Iowa, for example, 25 independent pharmacies have already closed this year, and I met with Hy-Vee, which is a grocery retailer that also has pharmacies. They're in 7 states. They're closing 2 pharmacies. And so if you have a multi-state company or national companies that cannot keep pharmacies open because of the cost and reimbursement, or reimbursing lower than what it cost a pharmacy to acquire the drug, these independent community pharmacies will close and are closing. When the FTC testified in front of the Energy and Commerce Committee earlier this month, the witnesses confirmed that your companies have not been complying with document requests, and that was true of my first bill in Iowa. We were supposed to have data within a year. It took 3 years to get data that was already in the possession of the PBMs. If your companies are so convinced that they can lower drug cost and increase access to innovative treatments for patients, you should be eager to demonstrate and not withhold information. Patients in my district are getting squeezed at the pharmacy counter and are seeing access to life-saving medications restricted. This is why I'm actually proud to lead these multiple bills to reform the drug pricing landscape to ensure PBMs and insurers are actually helping patients. Questions to any of you 3. Many experts recognize that misaligned incentives in the current payment system have led to PBMs to favor medicines with high list prices and larger rebates or discounts. However, when your companies faced exposure over this rebating practice, PBMs have shifted their compensation models to focus on administrative or other fees, which have typically remained tied to list prices. So even in the cases where PBMs are passing most of the rebates back to health plans, PBMs still have an incentive to favor high list prices. In doing so, the current PBM compensation model is causing patients to face a higher financial burden for their prescription drugs. In my view, PBMs should not tie their compensation to the price of a medication, especially a percentage of the medication. That seems counter to your stated mission of lower drug costs. Don't you agree, Mr. Joyner? Agree or disagree?
So we've actually introduced a biosimilar at a low list price. So we do believe that introducing products at a low list price is actually beneficial for our customers and the patients in the PBM.
Thank you, Dr. Cosner.
Congresswoman, we have been on the record for years of employing drug manufacturers to lower their list prices and continue to do so.
And Dr. Conway?
We want manufacturers to lower their list prices.
I would like PBMs to have a reduction in the amount of a drug that they're putting into the billions of dollars that are in this marketplace, and we'll continue on the PBM reform that I've started on. Thank you so much, Mr. Chair. I yield back my time.
Thank you. Chair now recognizes Ms. Lee from Pennsylvania.
Thank you, Mr. Chair. In southwestern Pennsylvania, we are deeply familiar with the consequences of concentrated corporate power in our healthcare systems. Whether it's a hospital system, a health insurance conglomerate, or both combined, the consequences of healthcare monopoly are always the same: higher costs, reduced access, and worsened health outcomes. And with health insurance companies like United Health, Cigna, and Aetna, it's evident that through their monopoly power, they've been able to rig our healthcare system to prioritize profits over patient health, capitalizing on each level of the drug supply chain to boost shareholder returns. Last year, the parent companies for all 3 PBMs testifying here today were incredibly successful, as evidenced by their windfall profits. And I know that some of my colleagues before me have gotten at this, but I'm still curious. Mr. Joyner, how much total revenue does CVS Health report in 2023?
Just shy of $180 billion, I believe.
And how much of that total amount was attributable to Caremark?
Oh, the question was CVS Health?
Yeah, but then how much of that was attributable to Caremark?
So the Caremark revenues were just shy of $180 billion.
Thank you, Mr. Costner. How much total revenue did Evernorth Health Services report in 2023?
Congresswoman, I don't know the exact amount, but it's certainly within the filings that we provide. What I can say is...
Yeah, I believe it's $153.5 billion. How much of that total was attributable to Express Scripts?
So we don't report the Express Scripts segment on its own, so I couldn't provide that information.
Thank you. Dr. Conway, how much total revenue did United Health Group report in 2023? I'm sorry, Kent.
Sorry. I believe it was in the high 360 billion in terms of revenue for the whole group.
How much of that amount was attributable to Optum Rx?
116 billion was the revenue of Optum Rx last year.
So while your three companies earn billions, Americans continue to pay some of the highest costs for medications in the world. Last March, the Kaiser Family Foundation released data showing more than a quarter of adults said it was either somewhat or very difficult to afford prescription drugs. For people of color, 60% of Black respondents and 65% of Hispanic respondents reported difficulty affording health care. And this is despite your claims of negotiating significant rebates from drug manufacturers to lower drug prices. So to any of you, it appears that this system of rebates actually benefits the PBMs rather than the patients, as we've been talking about. How do you explain this discrepancy? Anyone? Dr. Conway.
So we compete in a market that is competing on lowest net cost to the customer, clinical programs, transparency, and choice. It's a highly competitive market. I've been in this role for about a year, and our retention rates are 98+% in Optum Rx. And within that market, we work each and every day to make drugs more affordable, to your point.
But they're not more affordable.
So as I mentioned earlier, we've got over 290 drugs now in a program we rolled up that is $0 or $5 copays, so less than $35, typically $0 and $5. I agree with you that we need to continue to work along with stakeholders across
Thank you.
the system,
Yeah, thank you for
pharma
that.
manufacturers to make it more affordable.
Thank you. Just stick in there. Last year, Optum Rx's former CEO testified before the Senate Committee on Health, Labor, Education, and Pensions. She explained that some of your customers, quote, choose to compensate us for the savings we generate in the services we provide by opting for us to retain a small fraction of discounts we negotiate with pharmaceutical manufacturers. For companies that choose this compensation model, what percentage of the discount you negotiate with drug companies does Optum Rx retain on average?
The majority of customers choose 100% rebate pass-through. On average, across the entire book, it's 98% of rebates that are passed through to our customers.
Your former CEO stated that, quote, other customers prefer that we pass along 100% of the savings we negotiate. So on average, how do clients who choose this model pay Optum Rx as an administrative fee?
They have a set of choices in how they pay us. Some of them choose administrative fees. There's a set of options that we provide to them transparently that they select and how they reimburse us for our services.
It's clear that the savings you are claiming to be providing to patients are either woefully inadequate or not reaching them at all. I look forward to working with my colleagues to rein in PBM monopoly power and lower drug costs for all patients. And I thank you all for your time. I yield back.
Chair now recognizes Mr. Sessions, Texas.
Mr. Chairman, thank you very much. Thank you to the panel that has spent a good bit of time here. I am a strong proponent of the free enterprise system and of capitalism, but along with that comes something which you find yourself embroiled in today, and it's not new to you, and that is the view that a few PBMs control more than 80% of the market. And part of the free enterprise system, or at least capitalism, is opening markets up. You and I both understand, and that's fine, because I use some of them back home, larger pharmacy chains that then have some bit of influence about where the market goes, where the drugs are given out. But as I read about what's called spread pricing, it then disturbs me, and that is really why we're here today. I think why the chairman's here, why the ranking member's here, why all these members are coming forth, because we think that, and it's best said here, due to PBM's role as middlemen and their responsibility to reimburse pharmacies for dispensing drugs, PBMs can reimburse pharmacies that they own more than they give to competing pharmacies, such as community and independent pharmacists. But it really is a little bit more than that as an example, and that is maybe others are not even included in options that are available at the time they order their drugs. One example may be Blink that I'm aware of. Blink has a number of employees in the district that I represent, and they are, once again, just like you are, part of the free market, part of doing things, but they are part of the free enterprise system, part of the effort to provide competition, which is a basis of how we as Republicans think. Tell me about the ability that companies have, perhaps their pharmacies, perhaps their insurance company, perhaps they are you, about blocking competitors rather than allowing what might be an opportunity for customers to more fully get the carrier or the provider that they want. Anyone, Mr. Joyce?
Yeah, Mr. Joyner, thank you, Congressman.
Joyner.
So the networks work differently by market type. So in Medicaid, as an example, it's an any willing provider, which essentially means that anybody can participate, assuming that they're agreeing to the terms and conditions of the contract. As you move to the commercial, where you actually deal with employers, employers have different needs, and many of them are looking to either open up a network because they want to make sure it's open access, but they're also, as a result, generally paying more money. There are others that are looking to save money, and they want to restrict and or narrow the network. And so what we do is facilitate the options and help them actually make the decisions that are best for them, ultimately trying to cater to the employer choice and making sure that we actually show them options to be able to create savings and or a better experience for the employees they serve.
So preferred customer. This is not unusual.
Correct.
What you're describing is a part of the system. And that's what you're saying, that you, in working with the people who contract with you, make the decision. At what point then, with either any of you three, would a person without an employer, without, where probably a vast number of Americans are, who's looking out for them?
So the employer and or those that are providing the benefits for them are looking out. Most employers that you talk to want to make sure that they're offering a benefit that's attractive and is seen as a benefit because they're spending a lot of money on health care for their employees. So they are looking out for the well-being, and they're expecting us to deliver best-in-class service and also making sure that we deliver the savings to be able to provide an affordable benefit.
So they would come to you and say, and you would say to them, by coming to us, here's a benefit that we give to you, and by a larger amount of dollars that you would spend with us or numbers of customers, we would give you a preference. Okay. Mr. Chairman, I asked for just 30 more seconds.
Go ahead.
So what this group of people here are about, members of Congress, we do not see where that's necessarily open to better competition, better prices, and to people who may be left out of those equations. They may not have an employer-provided benefit. They may not have a preferred company that would advocate on behalf of them. And I think if we were being realistic, we would say, and say to you too, that's why we're here today. We would like there to be the same advantage for a larger number of people than is available today. And I think you can accept that and not argue with it. Look, I spent 16 years at AT&T. Not everybody came to AT&T. There was a more robust market. There needs to be a robust market for people that don't have advantage. I appreciate each of you being here today. Mr. Chairman, I yield back my time.
Chair now recognizes Ms. Porter from California.
Mr. Joyner, before the COVID vaccine, what was the highest grossing drug of all time?
I'm sorry, before the what?
Mr. Joyner, before the COVID vaccine, what was the highest grossing drug of all time?
Humira.
Humira. That's because for 20 years, Humira was the only option. for rheumatoid arthritis patients. People didn't have cheaper alternatives, and they literally ended up paying the price. And that price, without insurance, was a whopping $7,000 per month. And before you decide to put all the blame onto AbbVie, the manufacturer of Humira, I will remind you that I had some choice words for AbbVie's CEO. So we already know they're a big part of the problem here. But good news, in 2023, Humira's patents finally ended and cheaper biosimilar drugs came on the market. So Mr. Joyner, by the end of 2023, how much of the market did Humira's competitors control?
Less than 1%.
Wait, you're telling me that patients had the option to get a much cheaper drug, and almost everyone wanted to pay more money to get Humira? Make it make sense, Mr. Joyner. Were the biosimilars not as clinically effective?
No, it's a great question, Congresswoman. And generally speaking, the products that came to market initially were priced more like brands. So we actually was part of working with another manufacturer, bringing a product to market that was actually 82% less than the list price of Humira. And in April of this year, we actually removed Humira, the most successful product in the country, from our formulary. We converted 97% of that volume. In fact, in just 3 weeks' time, we moved more market share than all was dispensed in 2023.
Mr. Joyner, that's remarkable. Why did it take a year and a half?
We believe because...
Was it because you were waiting until you could manufacture your own version of Humira called, I believe it's Hyrimoz?
So we actually brought a product to market in April because that's when we believed that there was enough manufacturing capacity.
April of 2024.
Correct. We saved 50% off of the 2022 spend, $500 million worth of savings for our customers, and the patients basically paid $0 out of pocket. So it was a really great success story.
There's no doubt that Humira having competition has been a good thing. But you waited over a year from when the Humira biosimilars became available to put them on your drug list. Yes or no?
So not a year from when the Hyrimoz product was introduced.
No, let me repeat the question. Let's try to get an answer. How long did CVS, yes or no, Caremark, wait a year to add Humira biosimilars to their drug list?
No, we added biosimilars to our drug list in 2023. We didn't remove Humira until April.
So a patient would have paid the same for Humira and the biosimilars at that time?
They would have also had copay support, so they could have had gotten the benefit of a $0 out-of-pocket cost.
How much did CVS receive in rebates from Humira's manufacturer, AbbVie, in 2023?
I'm not certain.
Mr. Chairman, I ask unanimous consent to enter into the record a Kaiser Family Foundation Health News article titled, "Save Billions or Stick with Humira, Drug Brokers," that would be you all, "steer Americans to the costly choice."
Without objection, so ordered.
So that article says that Humira's rebates were at least 40 to 60% of the drug's list price in 2023. Does that sound right to you?
It's in the ballpark.
Okay, so let's use the low figure of 40% being the rebate off the list price that you negotiated. This is your value in the marketplace, correct? Negotiating this rebate. How much did Humira generate in sales in 2023? Do you know?
I do not know.
$14.4 billion. What's 40% of $14.4 billion?
So 52?
Pretty good. Pretty good math. $5.6 billion. Did all that money that you got as a rebate, did it go to patients?
The rebates were passed through to our customers, the employers, the organizations that fund healthcare in this country, and then they use those dollars, in some cases, to actually pass it on to the members.
You didn't retain any of that rebate?
As we mentioned in my opening statement, CVS Caremark retains, passes through 99+% of all the rebates that we negotiate with the manufacturers.
Look, I think here's the problem. Pharmacy benefit managers today are the worst kind of middlemen. You stop competition, you prevent transparency, you manipulate markets, and you make our healthcare system more complicated. Dr. Kutzner, you said healthcare is hard. No. The practice of medicine is hard. Healthcare is just a profit center in this country. I yield back.
Gentlelady yields back. The chair now recognizes Mr. Buddy Carter from Georgia.
Thank you, Mr. Chairman, and thank you for allowing me to wave on. And gentlemen, thank you for being here. You know, I want to congratulate you. You've done something that very few people have been able to do, and that is to bring bipartisanship to Congress. I'm so impressed with the testimony and the questions that have been given here today. They are spot on. Because at the end of the day, we all want the same thing. Whether you're a Republican, whether you're a Democrat, whether you're independent, you want accessible, affordable, quality health care. All of us want that. This is why we're here today. I want to bring it to a more personal note. And the reason I want to do that is because, as you know, I'm a pharmacist, and I practiced pharmacy for over 40 years. And patients come to me. In fact, last week in my office, I had a phone call with the mother of Maddie. Maddie is a 15-year-old from Georgia. Maddie has a rare genetic disorder called spinal variant neurofibromatosis type 1. Tumors grow on every single level of his spine and in his chest wall. This is a picture of Maddie behind me. The family asked that I share this with you. Mr. Joyner, CVS Caremark denied Maddie's access to a life-saving drug, Pulmozyme, that he had been on for 2 years. And he almost died as a result. In fact, he ended up in the hospital. He's still in the hospital. He's back in the hospital for the foreseeable future, and the rest of his life could be impacted because of it. All of a sudden, he'd been getting this drug for 2 years, and CVS Caremark came in and said, you don't have a diagnosis for it. Can you tell me, what would you say to Maddie's family, Mr. Joyner? What am I supposed to, as a pharmacist, what am I supposed to say to Maddie's family about this?
Obviously, this is a terrible situation, and I certainly feel sorry for the way in which this case has proceeded.
Do you feel like CVS Caremark's providing quality care to Maddie?
I do not know the specifics of this case. I will say that we do follow evidence-based guidelines, and so the goal is to make sure that we are looking at each individual case as it relates to the evidence.
I just want to make sure, Dr. Costner and Dr. Conway, that y'all understand we're talking about real people here. We're not talking about just a business model. Yeah, I was a business owner for 32 years. I owned 3 pharmacies, institutional pharmacy, a number of businesses. But we're talking about real people. After all, for 40 years, I was the one who had to go to the counter and tell the patient how much the medicine was. I was the one who watched a senior citizen make a decision between buying groceries and buying medicine. I was the one who watched a mother in tears as she tried to figure out how she was going to pay for the antibiotic. That's why when I got up here 9.5 years ago, the first thing I did was go to the FTC. Will you please look at the vertical integration that exists in the drug pricing change? Finally, 2 years ago, they started doing that. All of you are familiar with the 6B study and familiar with the interim report that came out. Mr. Joyner, are you familiar with it? Did you have a chance to read it?
I am familiar, and yes, I have read it.
Dr. Costner?
Congressman, we
Are you
strongly-
familiar with the report, and have you read it?
I'm familiar with it, and we strongly disagree with it.
Have you read it?
I have read it.
Okay. Dr. Conway?
Yes.
You have read it, and you're familiar with it.
Yes.
Mr. Joyner, does CVS Caremark in any way steer patients toward their own pharmacy? Yes or no?
So as we mentioned earlier
Yes
today,
or no, do they steer patients toward their own pharmacy?
We do not steer patients.
Okay, Dr.
provide options
Costner?
to our customers.
Yeah, I will.
Our clients make their benefit design decision.
No,
and they
yes
decide
or
on the
no?
network.
No. I'm going to take that as a no. Dr. Conway?
No.
No. Are you familiar with the report saying that there is evidence that the FTC has that the three major PBMs in this country, your three companies, are steering patients toward their own pharmacy? Are you familiar with that being in the interim report in a 6B study? Mr. Joyner?
I certainly read that, but I do not agree with the findings.
Okay, Dr. Kosman?
Congressman, the interim report is full of prejudgments. It lacks any economic, empirical, or data analysis.
Are you familiar with what they say?
I'm familiar
in
with what
steering?
they said.
Yes.
We've provided over 3.3 million pages of documents and would employ the FTC to do what they committed to do, which is a wholesome review.
And let
of
me
all of the
assure
data.
you they are doing it. Dr. Conway, are you familiar with it?
Yes, and we
And you
provide
still
choice.
deny it?
And we provide choice to our clients in their pharmacy network design.
Look, guys, you're not talking to somebody who doesn't know what's going on. I signed those contracts with the PBMs as the owner of Carter's Pharmacy. I know what they say. I know how I'm limited. The first bill I got passed up here was the right for the pharmacist to tell the patient if they paid cash that they didn't have to use, that it would be cheaper than their insurance. Because you had a gag clause in there that said that the pharmacist couldn't tell the patient that it would be cheaper if they paid cash for it. I was able to get legislation passed that changed that. There's only one word I know to describe this, and it's despicable. Mr. Chairman, I yield back.
Gentleman yields back. Chair now recognizes Mr. Lynch from Massachusetts.
Thank you, Mr. Chairman. First of all, I want to thank the chairman and the ranking member for putting this hearing together, and I want to associate myself with the remarks of Mr. Carter about the refreshing opportunity to work across the aisle with him and others on this problem. I'm the former chairman of the subcommittee on federal workforce on this committee, and I can go back to the year 2005 when we looked at what was happening with pharmacy benefit managers in prescription drug pricing under the Federal Employees Health Benefit Program. Our investigation revealed that the Federal Employee Health Benefit Plan, now this is the gold standard among affordable health insurance programs. It covers 8 million federal employees and retirees and family members. So this is one of the biggest and best funded because you got 8 million people paying into it. Our investigation revealed that the Federal Employee Health Benefit Plan was regularly paying up to 45% more for its prescription drugs than other federal programs, including those administered by the Department of Veterans Affairs and the Department of Defense. The single primary reason for the inflated cost of prescription drugs was that, contrary to other federal programs, the Federal Employee Health Benefit Plan did not negotiate or regulate drug prices for employees and enrollees. Instead, the programs relied on pharmacy benefit managers, PBMs, to negotiate prescription drug benefits and maintain affordable prices. So here's how bad it was. At the time we were doing this, CVS had a program where any person off the street could come in, and for $10, they could gain access to the CVS Caremark program. So someone off the street could walk in and pay $10 and get their drugs at a fixed price. In contrast, any of the 8 million people who were paying into the Federal Employee Health Benefit Program was paying 45% more, 45% more than the person with no insurance. So think about this. If I'm one of the 8 million employees or enrollees that are paying into their insurance program, they would be better off putting their union card in their shoe, walking in off the street without insurance, they would get a better deal than the PBM was getting them for their plan. So, in other words, the person with insurance under the federal employee plan was paying $200 more for the drug than the person walking in off the street. That is just absolutely ridiculous. The PBMs were harming the very people they were meant to protect, the people that they actually had a contract to provide affordable drugs for. This has to stop. This has to stop. Back when we tried this before, PBMs were spending money all around the hill and unfortunately spinning a story that was not factual and that won over some of my colleagues, and we were not able to get that bill to move. I just hope that, Mr. Chairman, with your leadership and the ranking member's leadership and my brothers and sisters across the aisle, let's work together on behalf of America today. Let's put all the other stuff aside and fix this problem. It is far too long in coming. Thank you, and I yield back.
Gentleman yields back, and I agree, and we'll make that pledge. Chair now recognizes Ms. Harshbarger from Tennessee.
Thank you, Mr. Chairman, and I thank the gentleman for being here today. First of all, I want you to know I've been a pharmacist for 37 years, and I know firsthand how pharmacy benefit managers maneuver in the shadows to put honestly, to put financial screws to independent pharmacists and community pharmacies. And I've worked in every area of pharmacy except nuclear. So that includes hospital, that includes retail, home health, hospice, the whole 9 yards. And I've lived that experience, being an independent pharmacy owner. You know, what happens is it leads to, when you have PBMs to do these things, it leads to increased drug prices by steering prescription drug coverage to whatever pads your bottom line. And the case in point is the FTC interim report that just came out. But before I get into that, I want to ask you a question. It's really just a yes or no question. The Centers for Medicare and Medicaid Services issued an FAQ during the COVID public health emergency, stating it was a Medicare Stark violation if a medical practice delivered a drug to a patient, and that during the public health emergency, there were Stark waivers in place which have now expired with the end of the public health emergency. For the record, I ask each one of you if you have had any communications with CMS that prompted this FAQ or related to it in any way, and if so, what was the communication? Starting with you, Mr. Joyner.
Yeah, I'm not familiar with the ask.
Okay.
Congresswoman, I'm not aware of what you just asked.
Okay.
Not that I'm aware of.
Thank you. Now, Mr. Kotzner, we've had the findings of numerous independent studies and the findings of the July 9th FTC interim report, and it's well documented many times over that certain medicines get marked up by thousands of dollars per prescription when they tend to flow through pharmacies owned by the same parent company as the PBM setting the prices. And per the FTC interim report, it states PBMs are paying their affiliated pharmacies up to 40 times average acquisition costs or more. And there is an internal document, if you've read the FTC interim report, that says an executive of one PBM stated in internal documents, you can get imatinib at a non-preferred pharmacy like Costco for $97, at Walgreens, which is a preferred pharmacy, for $9,000, and at preferred home delivery for $19,200. And it goes on to say, we've created plan designs to aggressively steer customers to home delivery where the drug cost is 200 times higher. The optics are not good. So my question to you is, how can the American public trust PBMs when they have done nothing to help with the pricing behaviors, and then you interfere with the clinical decision-making process as well, with physicians, with prior approvals and things like that? How can we, how can the American public ever trust what the pharmacy benefit managers are doing?
I appreciate the question, Congresswoman. So each and every day, we process millions of prescriptions. On every one of those prescriptions, we perform 18,000 safety,
Well, I know that.
quality,
Believe me, I've
benefit
read the
checks.
report.
And within 1 second, we're able to do determination. We're going to prevent 100 million potential medication errors just this year alone.
Okay, I'm going to the next question. We're going to talk about 340Bs. I'd like to ask each of the witnesses a yes or no. Does your company profit off of its involvement in the 340B drug discount program? Yes or no? Mr. Joyner?
The 340B marketplace today is an issue with our customers because the manufacturers are only paying.
Well, do you
discounts
profit
one
or
time.
not? It's a yes or no.
We do participate in the 340B program, yes.
So I would assume you do. Yes, Mr. Costner?
So the Cigna Group does have pharmacies that will participate in a 340B program, as do many pharmacies across this country.
We also have areas and customers where we participate in 340B.
Well, this is what I would like for you to do, is give me a report back to the committee. Give me a rough estimate of how much money your company collects due to its involvement in the 340B program. And we'd appreciate you following up with Chairman Comer with that information, and I or one of my colleagues can submit a written question for the record. Mr. Joyner, we've seen disclosures from your company, the fourth largest for-profit company in the country, warning investors that any reduction in 340B contract pharmacy arrangements could materially and adversely affect the company. And I find this confusing and alarming because the 340B discount program is intended to support safety net clinics and low-income patients, the underinsured or the uninsured. So can you please explain exactly how this federal safety net program became such a large part of your company's bottom line that you felt the need to inform investors that your profit would be negatively impacted by changes to the 340B program?
So, Congresswoman, as you know, the 340B program has changed over the last several years. We actively participate with health systems to help support their 340B programs. We do have pharmacies that participate within as a contract pharmacy with those health.
Well, why would an independent pharmacy get a contract and says this is your reimbursement rate if the 340B stays in place, and this is your reimbursement rate if it doesn't, if we negate it in Congress?
No, I think if you look at the change in the 340B laws, the amount of, or the activity of contract pharmacies shrunk or contracted, based off the interpretation of recent court rulings. So as a result, the narrowing of the 340B.
Well, they found a way to rape the system, is what it amounts to. And it's not just the pharmacies, it's some of the hospitals as well. And I think you need to relook at the 340B program and how you're abusing that program. And I know that my time is up, Mr. Chairman, but let me say this. Celeste Malloy, Representative Malloy from Utah, was here, and she waited over an hour, and she has a 2 p.m. Hearing, and I just want you to know that we'll be working with her in finding solutions for this. So with that, I yield back, sir.
Gentlelady yields back. Chair recognizes Mr. Achiklas from Massachusetts.
Thank you, Chairman. Long day, gentlemen, almost over. All three of your companies are part of the Pharmaceutical Care Management Association. Is that correct? Yes. And I see the PCMA is here today as well. The PCMA responded to the FTC's interim report with a statement that said, amongst other things, that the report is based on anecdotes and comments from anonymous sources and self-interested parties. The PCMA said the report was supported only by 2 cherry-picked cases. PCMA said the report completely overlooks the volumes of data that demonstrate the value that PBMs provide. Do any of you three want to disassociate yourself from those comments about the FTC report, or do you stand by those?
We stand behind them.
We stand behind them. I found the FTC report compelling. I found it also to be supported by excellent investigative reporting by the New York Times, by the Wall Street Journal, by a recent report from 3-Axis Advisors examining Washington state employer data, by a June 2023 MedPAC report that found that payments were likely to be highest to pharmacies that are affiliated with the PBM and prescription drug plan, while non-vertically integrated pharmacies were most likely to receive the lowest payments. I thought that the evidence fact pattern was quite strong. But given the claims of PCMA, and in particular, Mr. Joyner, the claims that CVS has made about true cost, I decided to do my own investigation in Massachusetts, got access to a Fortune 500 employers' data in Massachusetts, and looked at their benefits, which are administered by CVS. And this data here is not anecdotal. This is CVS's own data for an employer based in Massachusetts. I'm going to throw out two prices for each drug name, and I want you to guess, Mr. Joyner, which drug is the price CVS charges the employer and which drug is the NADAC price. And I wish that one of the pharmacists in the audience here could help me with these drug names. But we've got teriflunomide, which is used to treat multiple sclerosis. It's priced at $6,000, $229, or $16. Which one do you think is the CVS true cost and which one is NADAC?
If it were the true cost price, it would be the lower.
Well, that's interesting because the answer is the CVS price is $6,229 and NADAC is $16. That is a 38,000% markup.
Yeah.
Abiraterone acetate is used to treat cancer and is priced out at $91 or $5,800. Which one is the CVS price, do you think?
If that client has adopted the true cost.
The CVS price at $5,800, NADAC at $91. That's a $6,300% markup. I can keep going. We've got prostate cancer, 6,000% above NADAC. We've got leukemia, 13,000% above NADAC. Chronic kidney disease, 5,000% above NADAC. HIV, 4,000% above NADAC. Heart failure, a modest 161% markup above NADAC. These are not aberrations, Mr. Joyner. These are not anecdotal. This is your data in my home state. And while specialty drugs may be used by less than 2% of the U.S. population, they account for over 50% of the drugs spent. So if there's any cherry picking going on, it isn't by the FTC, regardless of what PCMA says. It's by the big PBMs. You are cherry picking drugs to apply them to specialty rates at specialty formularies. There is a clear pattern of marking up drugs used to treat the sickest patients, and you are marking these drugs up and filling them disproportionately at your pharmacies through steering. These kinds of markups are anti-competitive. They should be illegal, and that's why, along with my colleague from Tennessee, Ms. Harshbarger, we introduced today the Pharmacists Fight Back Act, which will stop these markups, the patient steering, the patient exploitation in federal health care plans, and impose criminal violations for such behavior. No more exploiting the sick, no more drugs being priced thousands of percentage points above NADAC, as I just listed here, and steered to your affiliated pharmacies. No more underwater reimbursing independent pharmacies or imposing point-of-sale and retroactive fees. These practices must stop. Transparent pricing and patient choice should be our North Star. Dr. Kotzner, in my remaining time, I do want to pivot and ask you about Ascend, the GPO that you have domiciled in Delaware but operating in Switzerland. Switzerland's an interesting place to be operating. You don't have any plan sponsors there. The Ohio Attorney General thinks that you're doing that because you are trying to engage in anti-competitive behavior. Can you attest here under oath that every action being undertaken in Switzerland would be legal under U.S. competition law?
Congressman, Ascent Health Services is a healthcare group purchasing organization around commercial rebates. We have multiple owners within that organization.
But can you attest that everything that's happening in terms of sharing information about rebates, sharing information about negotiations, everything that's happening in Switzerland, would all of that be legal under U.S. law?
Congressman, I'm not an attorney nor an expert on Ascent Health Services, so that's not a question I could answer.
Will you commit to following up with my office to determine whether or not every action that's taking place in Switzerland would be legal, or whether Attorney General Yost is correct that it is in fact a way to sidestep U.S. antitrust law?
Congressman, we can certainly take that back and review your question and get back to you. Thank you.
Thank you, Congressman Auchincloss, and thank you for your leadership on this. I'm definitely getting on your bill with Congressman Carter, and I appreciate your joining us today. I had to leave the room before when Congressman Frost was discussing the matter of compensation. As Congressman Auchincloss just pointed out, there's huge profits being raked in on this business, and we want to know where the money's going. Dr. Conway, what was your compensation? I'm sorry, I was not in the room when this happened. Did you state what your compensation is?
I was the only one to answer the question. My base salary is $950,000. I believe the question was total compensation.
Total compensation is how much?
Total last year was a little north of $4 million.
$4 million, okay. And Dr. Kautzner, how about you?
So Ranking Member Raskin, the Cigna Group reports our top 5 highest paid executives in our annual report. I am not one of them. I'd be happy to follow up with you offline.
Oh, that's too bad, but what was your compensation last year, not the top 5?
As I said, I'd be happy to follow up with you offline.
Wow. All right, Chairman Comer, what was your compensation last year as a United States Congressman?
Same as yours, 174.
174,000. Congressman Sessions, how much did you make as a congressman for the United States House of Representatives last year?
Including, I'm half paid. I retired and came back, so half is about a pension of 22 years, and then half is the remaining. So I'm trying to be honest about that.
Yeah, I wasn't aware of that particular mechanism.
Yeah, they net you. I can make no more than 174,000, but half of it was a pension from serving 22 years.
I got you. So, but your take home would be 174,000.
I'm not allowed a penny more.
Well, thank you for laying that all there out in public.
But you asked.
Dr. Keltzner didn't want to do that. Mr. Joyner, how much was your compensation last year?
So CVS Health has a top 5. They publish the top 5, and I am not part of the top 5 compensated employees.
All right. What was the bottom 5 of the top 5 at your company?
I am not aware.
What was the top 1 of the top 5?
I think as reported earlier, I think it was $20+ million for our CEO.
20 million was the highest paid
That was
person.
what was reported earlier.
Okay.
I can certainly confirm that.
All right. Well, there's a lot of money being made out there, and a lot of pain and a lot of hardship. You know, your companies are taking a huge chunk of money out of an already staggeringly expensive and inefficient system, a system so convoluted that most people don't even know that your companies exist. And so a lot of people are profiting from the opaqueness, the complexity, the convolution of this healthcare system. And we really have got to clean it up. And I wish that you guys would be part of the solution to help people understand instead of part of the problem. The FTC interim report said that not all the companies had complied fully with their requests for information and documents. Mr. Joyner, has CVS Caremark produced all of the responsive documents to the FTC, and you're under oath?
We believe we are in full compliance. Multi-terabytes of data and millions of pages of documents that we believe we're in compliance and on time with the FTC request.
So you have produced all responsive documents, that everything they've asked for, you've produced?
We believe we have produced what has been asked and requested.
Okay, Mr. Kautzner, how about Express Scripts?
So we have supplied, from what I'm told, 11 billion data points, 768 million rows of data, over 3
Right, I got you.
pages.
Yeah, those are all big numbers. Have you
We would
produced all
employ
the
we would employ the FTC, implore them to actually review all of that data, and we believe that
That's up
once
to
that
them,
data is
Dr. Kautzner.
reviewed-
Wait, I have such a simple question. Have you produced all responsive documents? Have you turned over what they've asked for?
As I said, I know we've supplied 3.3 million pages of documents.
Let's say it's
I'm not
87
aware-
zillion. That's not my question.
I'm not aware.
My question is, have you produced everything that's been requested?
I'm not aware of every request and wasn't involved in the turning over those, so that's a question we'd have
So you
to
don't
follow up
know.
with you on.
Your answer is you don't know. Okay. And Dr. Conway, has OptumRx produced all responsive documents to the FTC's requests?
Yes, I believe we have been fully compliant with the FTC requests.
Okay. I'm over my time. Thank you, Mr. Chairman. I'll go back to you.
Gentleman yields back. Just would like to ask you and ask consent to enter the following documents in the record. The committee's report on PBMs dated December 10th, 2021, the Federal Trade Commission's interim staff report on PBMs, a letter from the National Association of Chain Drugstores and the National Community Pharmacists Association, a letter from the Association of Accessible Medicines, a letter from the 60 Plus Association, a letter from the PBM Accountability Project, letter from a coalition of pharmacy and pharmacist organizations, a statement from Patients Rising, report by American Pharmacy Cooperative, Inc., a letter from the National Association of Manufacturers, and a statement from the National Association of Chain Drugstores President and CEO. Without objection, so ordered. I want to thank our witnesses for being here today. I know it was a long hearing. I apologize. We had to take a brief recess for House floor votes. Ranking Member, is there anything else you wanted to add before the end?
Yes,
Yep.
just one or two things. First of all, I want to thank you, Mr. Chairman, for two excellent hearings in a row, Monday and Tuesday. We've had a great week so far in terms of our ability to try to penetrate governmental or corporate bureaucracies that seem to be indifferent to a clear public interest. And I learned a lot from this hearing, I've got to say, and it's disappointing to me to learn about so many abuses taking place inside the system. And so we should act on this, Mr. Chairman. Again, we had clear bipartisan consensus here that this kind of profit-taking at the expense of patients, which is what the healthcare system should be all about, is really unsustainable. And we hear about it from our constituents all of the time. I understand that's not the principal concern of our witnesses today, despite the protestations that their goal is to save costs. No, their goal is to make money as corporations. That's the way the system is really operating, and that's fine. That's what they're doing. But we've got to protect the American people, and I hope we can act together to really try to reduce costs and make sure that everybody in America can get the prescription drugs that they need at an affordable price. I'll yield back to you, Mr. Chairman.
Gentleman yields back, and I agree and look forward to working with you on that. I've also been in communication with Brett Guthrie, who I believe has a good chance at being moving up in the Energy and Commerce Committee in the future. And this is something that we're going to have to work closely with the Energy and Commerce Committee on, because they have primary jurisdiction over a lot of what needs to be done. We had two members from Energy and Commerce here today, Ms. Harshbarger and Mr. Carter. They're both experts on the issue, and I'm sure there's some members on your side of the aisle that are on Energy and Commerce as well. In closing, I'm a little disappointed in some of the witness testimony today, especially the fact that you all claim to be transparent. Instead, you have created group purchasing organizations or rebate aggregators in foreign countries like Ireland and Switzerland, which I can assure you is the hardest country on the planet that's not a third world country to get any type of financial information, and pharmaceutical companies in Ireland and the Cayman Islands to evade taxes and congressional regulatory efforts. You have refused to answer questions posed by members on both sides of the aisle. The book's still open about your testimony with respect to your relationship with independent pharmacies. That one was hard to believe. You pointed the finger at manufacturers, even though PBMs are the center of the problem. You've taken no ownership of your actions or role in the rise of prescription drug costs. We get elected by our constituents. In my district, I have 740,000. How many do you have in your district, Mr. Ray?
794,000?
Yeah, 794,000. So we all represent probably between 700 and 900,000 people. And one of the biggest issues is the rising cost of prescription drugs. And that's a bipartisan issue. And there aren't many things that are bipartisan in this town, unfortunately, especially on this committee. But this committee is in agreement that PBMs need to be reformed. Now, we've passed bills in Congress, and state legislatures are passing bills increasing transparency. But as we've mentioned throughout the hearing, there are things that you do to evade transparency, much like going to foreign countries. We believe that some of these transparency bills are a lot like a resolution. You pass a resolution and we go back and say we did something to get people off, but a resolution really doesn't do anything. We need real reform. And I think that, I disagree with some of the things that were said by people across the aisle. I'm a free market guy. I'm all about making a profit. I think that risk takers should be rewarded for making a profit. Drug companies take significant risks. They invest in research and development. I do believe that they should be rewarded for that risk. If they're not rewarded for the risk, I don't believe we'll be ever discovering new medicines and new vaccines, because there's no incentive to discover new medicines and new vaccines. The PBMs were created to help drive down costs of prescription drugs. I don't think that's working. There are always going to be examples where you reduce the cost of prescription drugs, but overall, we have too many horror stories from pharmacists. We have too many horror stories from consumers about where they were gouged by the PBMs. And that's not what the PBMs were created for. And I don't believe the PBMs were created to be vertically integrated. I think that's a huge issue. And I don't know what our solution is for the PBMs. I would certainly support busting up the PBMs. I don't think a PBM should be owned by a health insurance company. I don't think a PBM should own a pharmacy at the very least. So I think we're going to have many more discussions. We do a good job on this committee of messaging. I think this report is excellent that we released today. We're going to continue to work and try to find a solution to the problem, and it is a problem. It is a problem, and we represent our constituents who demand that we do something about the problem. So again, I want to thank you all for being here. With that and without objection, all members have 5 legislative days within which to submit materials and additional written questions for the witnesses, which will be forwarded to the witnesses. If there's no further business, without objection, the subcommittee stands adjourned.
Enjoy more of our videos on the Community Advocate Network channel, and don't forget to like, share, and subscribe. If you would like to advertise your service, special announcement, or event, you may contact us at the Community Advocate Network at gmail.com. For community resources or services, visit our website at www.canmichigan.com.